Good afternoon, and welcome to Day 2 of MDA's Myotonic Dystrophy Virtual Learning Series. My name is Sarah Fuchs, and I'm a Senior Specialist in the Community Education Department here at MDA. This learning event is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to our website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their inbox. I want to extend a special thank you to our program supporters, Vertex Pharmaceuticals. For 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular diseases. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. It is my pleasure to introduce today's first speaker. It's Dr. Kaitlin Batley. Dr. Batley is a pediatric neuromuscular neurologist and the director of the Pediatric Neuromuscular Program at UT Southwestern and Children's Health in Dallas, Texas. After completing child neurology residency and pediatric neuromuscular fellowship at UT Southwest, Dr. Batley then joined faculty as an assistant professor of pediatrics and neurology, also serving as the pediatric neuromuscular fellowship director. She oversees clinical operations and manages a multidisciplinary team to provide care to children affected by neuromuscular disorders and their families. Dr. Batley is also involved in research, participating in over 20 clinical trials and a natural history study. Dr. Batley, thank you for being here today and for your patience, and I will now turn the time over to you.
Thank you so much. It's my pleasure to be here. So I'm just going to share my screen, and hopefully I'll have good luck. There we go. All right, so we're going to focus today on symptom management in myotonic dystrophy. And so just a couple of disclosures for work that I've done with some pharmaceutical companies, but none of which should be relevant to this talk. So today we will review some of the common symptoms and some of the less common symptoms that can be experienced by those who are living with myotonic dystrophy. And we'll talk a little bit about the medical management and some of the testing that might be done to assess for these things, and then options for treatment as well. And then talk about some resources. So just a quick background on myotonic dystrophy. I know that most on the call are probably familiar and had, a great introduction yesterday as well. So we do know that myotonic dystrophy is an inherited or genetic disorder, and it's inherited in a way that is called autosomal dominant, and that is typically passed down from one generation to the other. And there are two types of myotonic dystrophy, depending on which gene of the body is affected, with myotonic dystrophy type 1 or DM1 being caused by a repeat or kind of this expansion of a portion of the DMPK gene. and myotonic dystrophy type 2 being that same kind of repeat expansion in the CNBP gene. So these repeats are kind of like exactly what they sound like. They take a portion of the gene and they just keep repeating after itself. And we know that these repeats can be unstable. They can expand from one generation to the next. So for instance, from a parent passing on the condition to the child. And when that happens, we often see that the child has symptoms that begin earlier in life than maybe the parent did. And this is a term that we use called anticipation when it happens sooner. And we also know that these repeats can expand even in an individual person throughout their lifetime. And it can happen in different tissues, that some tissues have higher number of repeats than others. And that can cause symptoms in one organ system or one part of the body to be more significant than maybe in another part of the body, even in an individual person. So when we talk about what these repeats do, we know that they cause what we call an RNA toxic gain of function. And so this kind of disables the RNA from acting the way it's supposed to act, and it leads to production of abnormal proteins found in many different systems of the body, which is why we have this kind of multisystemic disorder or something that affects all different organs. And because we know that there is many different organ systems involved, we know that there are many different areas of the body that we need to monitor for these effects. So when we talk about myotonic dystrophy treatment as a whole, we know that this is really a multidisciplinary approach. And I'm so glad I know you got to hear from a fabulous endocrinologist yesterday who we work with as one member of the team, but there really is just so many team members that are important here: cardiologists, pulmonologists, physical and occupational therapists, and rehab specialists. And the multidisciplinary team might look different for different people depending on what their actual symptoms are and how myotonic dystrophy is affecting their body. At this point in time, we don't really have a disease-modifying therapy that's available, although with all of the amazing research being done, I'm very hopeful that that will change soon. And so right now, we really focus on management of symptoms of the disease and kind of trying to prevent complications and from things kind of worsening and to keep as much under control as we can. And so we'll start off with some of the neuromuscular symptoms that can be experienced by people with myotonic dystrophy. So one of the main symptoms that we can see is weakness of the muscles. And the patterns of weakness tend to be different depending on which type of myotonic dystrophy it is. And of course, these are kind of generalized statements and they might be different from person to person. So if your symptoms don't exactly fit, this little picture here, that's okay. Everybody is different. And so this will not be the case for everyone. But in DM1, we tend to see the more distal muscles affected. So typically muscles of the hands. So that can manifest as, trouble holding onto objects, opening jars, writing with a pen. And then in the lower extremities, we tend to see that the calf muscles and the muscles that are responsible for picking up the foot can be affected. And that can lead a lot of people to have what we call foot drop, whereby they can't lift up their foot. And so it can drag along the floor. It can lead to tripping and falls. And that seems to be a very common feature. We also know that people with myotonic dystrophy can have weakness of the face muscles. And so sometimes that will lead them to have some kind of decrease of musculature right around the temples that we call temporal wasting, and that's due to muscle atrophy. And then can see weakness with things like closing the eyes or smiling or puffing out the cheeks, and that's all due to facial muscle weakness. In DM1, instead of affecting the distal muscles, DM2, it affects the proximal muscles. So that is the hip and shoulder girdle muscles. And then also some of the neck muscles, so trouble like picking up the head from lying down. And this is, again, a general pattern and not pertinent to everybody. That's what we tend to see. When we talk about treatment for weakness, there is no muscle medication or anything that we can do to slow the changes to the muscles, but we do know that moderate intensity exercise can be really helpful, and physical therapy, which you'll hear more about in just a few minutes. And we do know that this kind of activity level is safe for people with muscular dystrophies. And, I think there's always been this kind of fear of, oh, if I do too much, I might cause worsening of muscle breakdown. But we also know that not doing anything can cause you to have muscle atrophy and muscle loss. And so I usually tell my patients, you don't want to be doing all out strenuous maximal activities, but you also don't want to be, sedentary. And there has to be somewhere kind of in the middle where we're getting a little bit of activity, but not overdoing it. Orthotics or braces can actually be very helpful, especially for those people who have that foot drop where they're unable to pick up their foot, because the orthotic can kind of keep their foot in a stable position and keep it from dragging on the floor and causing trips. And then some people will also need mobility aids, things like wheelchairs, to help them to be independent. And then another neuromuscular symptom that we often see is myotonia, which many of you are probably familiar with. And I did have got a video that I'm going to turn off the volume because the volume is kind of crazy, just to show, in case there are anybody on the call who hasn't seen what it looks like. You can see here that the examiner places their fingers in the palm, and the person's going to squeeze tight on the fingers. And then as opening the hand, they're having some trouble opening the hand to release the examiner's fingers. And as it goes on, you can see how eventually he's able to open his hands, but his fingers stay kind of cramped. And that's because of myotonia, which is an impaired relaxation of the muscles. And so in DM1, we tend to see this again involve the distal muscles. And so hands are really the most common thing that I hear my patients say. But in DM2, it tends to present with more kind of generalized stiffness of typically larger muscle groups, especially those big thigh muscles. And this finding is often not present in really young children and typically develops around adolescence. So those with congenital myotonic dystrophy, toddlers and little kids might not experience this, and we tend to see it as they get a little bit older. All right. So for myotonia, there are different medications that we know can be helpful. The one that we'll talk about in just a minute that's been around and used for the longest is a medicine called mexiletine, but there are also other classes of medications that have been useful, such as a medicine called lamotrigine. We also know that there are different kind of lifestyle modification ways that people can try to avoid their myotonia. Although they're not able to kind of completely make it go away, we do know that avoiding excessive cold can be helpful. And then also allowing some time for kind of warm up of the muscles before doing an activity can also help to manage it. So mexiletine, it is a prescription medication that would be recommended by your doctor if they felt, you were a good candidate. It's an interesting medication because it is actually a medicine that works on heart rhythms. And so it's what we call an anti-arrhythmic. And so it tries to prevent people who are at risk from having an arrhythmia or an abnormal rhythm of the heart. And but that's not what it's being used for in those with myotonic dystrophy. It has been found to be helpful for that stiffness or impaired relaxation of the muscles as well. And it's actually been used in myotonic muscle disorders for over 30 years. So there is actually a really good history with it. However, it does require some careful monitoring, and most doctors will recommend cardiac clearance before using it, because we know that in those who are at risk of heart problems, it can actually cause them to have an arrhythmia, which is kind of counterintuitive when in other people it's used to treat arrhythmias. So it's a very interesting kind of use of this medication, but it really shouldn't be used in any people who have a history of a heart attack or who have history of abnormal heart rhythms, such as atrial flutter or a type of kind of block in the electrical activity called an AV block. And as we'll talk about when we get to the cardiac symptoms, these are things, especially the last two there, atrial flutter and AV block, that can be fairly common in individuals with myotonic dystrophy. And so this medication does need to be used with caution. And so typically, I'll have my patients see a cardiologist before we start it. And then we also monitor by repeating EKGs after starting the medication and then after dosage increases to make sure that the medication is not causing any change in the heart rhythm that could potentially be dangerous. And so that's why this medication, while very effective, can have, some limitations with its use. And so other medications have been tried as well and can be effective in the treatment of myotonia. And so it really is a very individualized decision to determine kind of, is a medicine right for you, which one to use, and all of those things. So then finally, with our neuromuscular symptoms, we can see some of our individuals have orthopedic issues. This tends to be more common in patients who have onset of symptoms when they're younger. So our congenital myotonic dystrophy patients especially can develop scoliosis or kyphosis, which is an abnormal curvature of the spine, as well as joint deformities. Typically, problems at the ankle joint can be pretty common as well. We also tend to hear that those with myotonic dystrophy have significant component of pain. And this is kind of hypothesized to be kind of a twofold pain. So one is actual kind of the muscles themselves and the differences in the muscles, the sometimes breakdown of the muscles that occurs with having a muscular dystrophy, that can cause pain that's kind of individualized there. And then there's also this component of kind of a central nervous system sensitization or kind of increased heightened awareness of pain as well. And so the combination of the two together can lead to this chronic pain component that can be really, really impactful in day-to-day life and can sometimes be hard to treat. We do know that an exercise regimen as well as physical therapy can be helpful, and then stretching and massage. Some of my patients have found that supplementation with magnesium can be helpful for some of that muscle pain. And so I've tried that. And then also talking with your doctor to see if perhaps a neuropathic pain medication could be helpful as well on individual cases. So that was the muscles, but we know that myotonic dystrophy is truly a multi-system disorder. And so we have many other areas of the body that can develop symptoms and require management as well. So first we'll start with the respiratory system or the or breathing pulmonology. And so we know that those with myotonic dystrophy who have weakness of their breathing muscles can actually develop what we call a restrictive lung disease. And so the way I think about that is that the lungs themselves, like the actual organs and tissues, are healthy, but the muscles that help the lungs to do their job, which is to expand and take a deep breath and then to push that breath out, are what's not working correctly. And so because the muscles can't help the lungs to take in the air and then push it out, it can cause people to have trouble both getting in enough air and then breathing out the byproduct of your oxygen exchange, which is called carbon dioxide. And so we know that this can lead to people, not being able to take in enough oxygen. It can also mean that at nighttime, they're not able to breathe deeply enough to be able to get enough oxygen and can cause a condition called sleep apnea. We also know that apart from the muscles, the central nervous system or brain control of the way that we breathe can be impaired. And that can cause people with myotonic dystrophy to have kind of changes in their breathing patterns, and for them to maybe not respond as well to that buildup of carbon dioxide to then be able to change their breathing in a way that can help get rid of it. And so similarly to the chronic pain component, there's this both direct muscle effect on the breathing system, as well as the way that the brain is controlling your breathing system that are both impacted. So this can lead to excessive daytime sleepiness, so just fatigue and being tired, waking up in the morning feeling like you did not get a whole night's rest. Headaches in the morning are common. can be even frank trouble breathing when you're lying down, getting very frequent respiratory infections, coughs and colds and viruses and that kind of thing. And then some people will notice that when they try to cough, maybe it sounds a little bit weaker and they don't feel like they're really able to clear that cough or clear any kind of secretions that might be building. And so these are all things that people can notice as their breathing becomes affected by myotonic dystrophy. And so in myotonic dystrophy, we always recommend, staying plugged in with a pulmonologist who is knowledgeable about the condition, and, the routine clinical history and exam, and then a type of testing called pulmonary function tests, which this nice little graphic shows. They often put the nose clips on, and then you're breathing into a tube in certain directions, and this machine measures how hard and how completely you're able to move air in and out. And that's something that we do in the office and, can be done quickly. But then there are some other more extensive tests, things like a sleep study, where you actually have to go into a sleep lab and get hooked up to all the things, the stickers on the head and the face and the nose, and really have an in-depth study of the way that you're sleeping overnight to see, are you breathing deeply enough? And is the oxygen carbon dioxide exchange, adequate? In myotonic dystrophy type 2, we do typically see that respiratory involvement is less severe, but it still should be screened for as well with each visit. So as far as managing these symptoms, we do recommend that patients receive all of their age-appropriate vaccinations. That includes your flu shot, your pneumococcal vaccine, because we know that anyone who has any kind of respiratory or breathing muscle impairment will be at increased risk for having significant complications from these viruses. And so we want to protect, our loved ones as best we can. And so we do recommend these vaccines. Some people will also be recommended to start using different techniques and devices to help them clear their airway. So when we talked about kind of inability to cough hard and get out those secretions, there are different devices that can help with that. One type of device is called a cough assist machine, and it has, at least for kids, a mask that goes on the face, and it moves air in and out to kind of manually cough for someone and to help clear all those secretions. There's also things like shaky vests that put on and go, that help break up secretions. And then mucolytics are different medicines that can help thin secretions to make them easier to cough up. Some people will also require a little assistance with their breathing, especially at nighttime, with a type of machine called a BiPAP, which is a bi-level positive airway pressure machine. And this can help with some of that decreased breathing at nighttime. And so that could be recommended by your doctor as well. The next system that we will talk about is the cardiovascular or heart system. And so we know that in myotonic dystrophy, one of the biggest concerns is a change in the way that the heart conducts electricity. So your heart communicates with electrical signals. It tells the heart how to beat and kind of the timing at which it beats. So it squeezes at one part and moves the blood, and then squeezes the another part and moves the blood again. And so if there are any changes in this electrical system, then the heart might not be able to pump in a synchronized rhythm to get the blood, through to the lungs, back to the heart, out to the body. And so that's my neurologist understanding of cardiology. And so when there are changes to the heart from myotonic dystrophy, whether that's breakdown of any of the different heart cells or replacement of the heart muscle by kind of scar tissue and fatty tissue, this can change the way that the electrical signal conducts. And that can cause different kinds of rhythm problems, with atrioventricular block or AV block being one of the most common ones. And that's where kind of the heart rhythm gets stuck and it doesn't get all the way down to the ventricle. And this can have many different kinds of heart complications. And there have been reports of people who have passed away suddenly from an arrhythmia that is so severe. And so this is one of the biggest things that we watch for when monitoring someone who has myotonic dystrophy. We also know that with changes to the heart, we can get something called a dilated cardiomyopathy, which is where the heart muscle starts to get bigger and thinner. And as it does, it's not able to squeeze as effectively. It kind of, the muscle thins out and it just kind of collects blood and doesn't squeeze. And with both of these conditions, we can see an increased risk for stroke to occur. And a stroke is when typically, for one reason or another, a part of the brain does not get enough blood flow and thereby enough oxygen, and it can actually injure the brain. And so symptoms that we can see with these different cardiac problems, first and foremost, none, which is why we recommend that all of our patients with myotonic dystrophy regularly see the cardiologist, because even though someone might be feeling well and not noticing any particular issues, we know that the risk is there. And the idea and goal would be to kind of catch signs of these problems before they become a really big problem. And so sometimes rhythm changes can be so infrequent that maybe they're not very noticeable. And then someone who could have significant heart failure symptoms might be difficult to know that, you know, these changes are happening, because maybe if they do have significant weakness, maybe they're not able to kind of generate enough muscle activity to notice that they're getting, you know, more tired. Or if they already have really significant daytime fatigue, again, it can be hard to know if that's just from being tired from myotonic dystrophy, or is that from the heart not working right. And so it's very important to continue seeing the cardiologist regularly. We can also hear reports of irregular heartbeats or kind of funny palpitations in the chest. And then, of course, you know, talking about stroke earlier, the signs that we typically see with stroke would be kind of this acute onset of weakness, typically kind of one side of the body with facial droop and weakness of the arm or leg, as well as slurring of the speech. And those would be, you know, reasons to seek emergency care immediately and call 911. One of the things to note about myotonic dystrophy is that we can see these heart issues occur even before the onset of muscle problems, and so can sometimes be the first thing that triggers testing and the diagnosis. So we often recommend regular cardiac testing that can include an EKG, which is the stickers on the chest to watch the electrical rhythm of the heart for usually 30 seconds to a minute. And then some people will also need what we call a Holter monitor or a loop recorder, which are more long-term devices to watch the heart rhythm for longer periods. And then echocardiogram is an ultrasound of the heart that can be done in the office to look at the structure of the heart and the way that it's pumping and the function of the heart. And then now more and more we're using cardiac MRIs as kind of our gold standard to really look at cardiac function, as well as look for any kind of scarring of the muscle tissue. And so that's a test that we'll often perform as well. So the management can be very extensive and definitely outside of the scope of this neurologist, but we will see our cardiologist use a different regimen for heart failure prevention, depending on what the symptoms are. And then in some cases, our individuals with myotonic dystrophy will even need to have a device implanted to either help their heart to keep on rhythm, called a pacemaker, or even something called a defibrillator, which actually would detect an abnormal rhythm of the heart that's dangerous and give you kind of an electric shock to reset it. And so these can all be recommended for different reasons and can help keep a person safe who's got significant cardiac changes from myotonic dystrophy. All right, so moving on to the central nervous system. This is another area where this is very individualized from person to person, and there are some people who may experience several of these issues, and then there will be a lot of people who don't have any of these issues. But we do know that, especially for those who have earlier onset forms of myotonic dystrophy, that we can see impacts in different kinds of cognitive domains, and those tend to be most significant in kind of visuospatial perception as well as social interactions. We do know that those with myotonic dystrophy can have changes in the structure of the brain and the way the brain looks on things like MRI scans. both with what we call atrophy, which is kind of loss of some of the brain tissue, as well as different kind of scarring or white matter abnormalities that can be seen too, seen in these kind of patchy little white areas on this brain scan here. And so the symptoms of this can vary very widely, from cognitive impairment to features of autism, and different personality traits such as apathy or kind of a decreased interest in participating or doing certain things. And there's also a higher risk for depression as well. So these are all things that we discuss and screen for at our visits to see whether someone needs further workup with a standardized set of testing that we call neuropsychologic or neuropsychometric testing, which is a very kind of formal, regimented, usually kind of questions and solving puzzles. And it looks at the way that you process your memory, your attention, all of the different kind of facets of cognition or of thinking. And so we know that there are different ways that we can manage these issues depending on what the exact symptoms are. There have been studies that have found that a certain type of therapy called cognitive behavioral therapy have been helpful in improving activity level, physical activity level, as well as participation in social activities. And then for those who might have symptoms that fit with depression, there are medications that can be helpful in treating depression, or if it's an attention issue, there are medications that can be helpful there. And so some of it is kind of supportive in therapies, and then there are also medications that can help in different areas too. And so then moving on to sleep, which is kind of like a combination of the last section of central nervous system as well as breathing, because this is another area where we really see the muscles and the central nervous system playing together to cause some of the issues. So excessive daytime sleepiness or fatigue is a very, very common feature in myotonic dystrophy, and one of the most frequently reported bothersome symptoms that really impacts day-to-day life. And so this is caused by a combination of both that neuromuscular weakness, so trouble with the breathing muscles at night, as well as the way that the central nervous system controls breathing. And so in patients with myotonic dystrophy, we can see obstructive sleep apnea, which can be related to muscle weakness of the breathing muscles, as well as different changes that can happen to the face because of weakness of the facial muscles that can also narrow the airways and make it more likely to obstruct at night. We can also see central sleep apnea. So that's when the parts of the brain that are responsible for regulating sleep and telling the body how to go through the sleep cycles is not functioning properly. And then when you don't breathe as deeply at night, you get a buildup of that carbon dioxide or that oxygen byproduct, which then stimulates your brain to wake up. And so you're waking up a lot overnight and you're not able to get that good deep sleep because you keep waking up. And so these kind of controls of breathing, as well as some of the kind of extra abnormal movements that can occur, like restless leg syndrome or periodic limb movements of sleep, can make it really difficult to get a good deep night's sleep. And so because of that, we often just see that people feel like they sleep poorly. There have been studies that have shown that people with myotonic dystrophy spend overall a longer amount of the nighttime period in bed, but yet they're still waking up feeling tired and like they did not get enough sleep. And then some signs of sleep apnea can be that snoring or those apneic pauses in breathing at night. The most important and helpful test in these situations is a sleep study. And these, again, are done usually in sleep labs, although I think some adults will do home sleep studies, but in pediatrics, we only do in the sleep labs, to look exactly at the way someone is sleeping, how many times they wake up at night, do they have restless leg or periodic limb movements of sleep, what are their oxygen and carbon dioxide levels at night, all of these different things that they can monitor with a study. So as far as management, one of the most important things is one of also the hardest things to do, which is the sleep hygiene. And this is the, the set of recommendations that I myself don't always follow. We want to turn off our cell phones at least 30 minutes to an hour before bed, not watch TV before bed, anything that could stimulate you with that blue light we want to avoid. We want a nice kind of wind down bedtime routine, everything that we can do to prepare our body for a good night's sleep. And so that's always first and foremost. But if that's not helpful enough, then we can help the body to get a better night's sleep by using devices like BiPAP or that non-invasive ventilation at night. And then if even that is still not helpful enough, there are medications that can be used to help kind of counteract some of the problems with sleep, some of the problems that sleep cause, such as modafinil or other stimulants. And modafinil, also called Provigil, his other name, is a medication that is approved to treat excessive daytime sleepiness. It is a stimulant, but it's not an amphetamine. However, it is a controlled substance, and so it does require, special rules and regulations around prescribing. And it's typically well tolerated, although there have been reports of things like headache, nausea, and decreased appetite when starting. But I would say this is kind of the first line go-to for most people when combating excessive daytime sleepiness. But if this is not effective, then other stimulant type medications can be used as well. All right, so moving on to the next category, which is tumors or an increased cancer risk. So this is something that I think is still kind of being learned about. We do know that more common in DM1 are a type of benign tumor or kind of formation of cells causing a mass called a pilomatricoma. And this is a little kind of like nodule. It's usually firm, kind of calcified, that's under the skin, often on the face and neck, but can really be anywhere. And then there's also an increased risk for a variety of different kinds of cancers in different organ systems. The symptoms can really vary depending on what's going on, so that would be too long of a list for me to mention in this talk. But we do know that the recommendations for people with myotonic dystrophy for screening for cancer is right now still the same as the general population. So making sure that you get mammograms if you're a female, colonoscopies at the right time period. But I think it's really important for your doctors to be aware of the myotonic dystrophy diagnosis, so that way they can have a higher index of suspicion. If you were to develop some kind of symptom or some issue that's going on, to say, oh, maybe we need to do that colonoscopy sooner than we would do in a person without myotonic dystrophy, or whatever the situation might be. So that way, things can be changed around depending on the person and what's going on with them. So the management, of course, depends on which type of cancer, but the good thing for the pilomatricoma is that usually those can be surgically removed if they're bothersome, and then they don't usually come back. So that's relatively straightforward management for that one. All right, moving on to the gastrointestinal or GI system. This is another organ system that is very frequently involved in myotonic dystrophy. We know that GI symptoms can be very common and can really have a very high impact on both the individual with myotonic dystrophy as well as their families. We know that there is an increased risk of trouble swallowing, which we call dysphagia, trouble with bowel movements or constipation, which can even be so severe as to cause kind of blockages in the bowels and inability to go to the bathroom, which would be something that could require someone to go to the hospital. There's also increased risk for diarrhea, for reflux or that kind of heartburn symptoms, abdominal pain in general, as well as problems with the gallbladder, like gallstones, and different liver issues like non-alcoholic fatty liver disease. And so we do see these as a very commonly reported problem in myotonic dystrophy. So testing, again, will depend on what's going on, but swallow studies are pretty frequently ordered if there's any swallowing problems. There can be different ultrasounds done to look for causes of abdominal pain, like looking at the gallbladder. And then we're able to use different medicines to manage some of these symptoms, like using medications that kind of reduce the acid in the stomach to help with reflux symptoms. Some people will need laxatives or pro-motility agents to help combat constipation. And then there, of course, are different kind of lifestyle modifications. So maintaining a healthy diet and maintaining a healthy weight can be very helpful. We don't want to be too thin and thereby not getting enough nutrition. And then also don't want to have excess in calories and gain excessive weight. There is a higher rate of cholecystectomy or gallbladder removal because of the gallbladder issues that can occur. All right, getting through the chart. Moving on next to endocrine problems. And again, this can vary very widely depending on the particular person, but we do know that there's an increased risk for diabetes, for diseases of the thyroid, as well as for hypogonadism and dyslipidemia or problems with cholesterol and the lipids. We know that several of these conditions can affect the density of the bones, and that's why it kind of gets in the endocrine area. And for people who have weakness and are at increased risk for falls, this can also increase their risk for fractures of the bone, which can be dangerous. And so bone health and bone density management is also a really important part of care. So again, the symptoms can depend on the issue, but for hypothyroidism, we typically will see people who are intolerant to cold and are always feeling cold and grabbing extra sweaters. They might be gaining weight unexpectedly or have even more excessive fatigue that occurs. For those with diabetes, we typically see frequent urination and increased thirst. And hypogonadism can present differently in males and females. For males, we might see erectile dysfunction. And then for females, it might be changes in their menstrual cycle or loss of their menstrual cycle called amenorrhea. And so because of all these different issues that can occur, lab monitoring is usually done at least every few years to kind of look for these issues that can arise. And again, the management will depend on what's going on. For instance, if a thyroid disorder is found, then we can treat that with thyroid replacement. If it is a problem with the blood sugar, we can manage that as well. And so would require, meeting with your friendly endocrinologist. And the last couple of ones quickly. So eye issues are also common. We know that there's an increased risk for cataracts, which is that clouding of the eye. We also can see that people with myotonic dystrophy have droopy eyelids, which is what we call ptosis, due to some weakness of the facial muscles. And they can have difficulty also closing the eye fully. And so that can cause issues where the eye is just exposed too much to air. And so it can cause dry eyes. It can cause little scratches called corneal abrasions as well. And so typically there could be no symptoms and it's something that's picked up on a routine exam, or there can be some visual impairment, trouble seeing, dry, irritated eyes as well. So of course, recommended to see, depending on what's going on, it might be more frequently than once a year, but at least once a year to get a good eye exam. And the management will depend on which of these issues are occurring, but for cataracts, we know that those can be surgically removed. For ptosis or the drooping of the eyelids, there are little devices called eyelid crutches that can help to open the eyes so that you can see better. But then for some people who it might be very severe, they can actually have a surgical procedure done where the eyelids can be opened up a little bit. And then for those who have dry eyes, we can do patching of the eyes at night, so get like a sleep mask, as well as different eye lubricants, gels, drops that can be helpful in treating that and managing those symptoms. And then finally, one of the kind of least common things that I think that we see is that there is an increased risk for hearing loss. And so if you notice that you're having a little bit more trouble hearing, you can get your exam done and get your hearing formally tested. And then the treatment for that would be the use of hearing aids. But there are additional resources on myotonic.org as well. And then, of course, your medical team should be probably the biggest resource to you. So if anything stuck out to you today, be sure to follow up with your doctors who can kind of guide you on whether maybe this is applicable to you or maybe this is not something you need to worry about, and to get more information. So thank you all. And I think I saw some questions come through in the chat.
Yes, thank you so much, Dr. Batley. We will move on to questions, so feel free to continue to enter those into the chat. So let me pull up some questions. We also had questions upon registration, so we will start with some of those. Let me pull that up here. So our first question is, how common is pain with myotonic muscular dystrophy, and what type of pain is common? I know you've reviewed
Yeah, no,
quite a few.
But it's a good question because it is, I think, very common. And pain is very difficult because it is so subjective and it's not something, there's no test that I can do. There's no blood test or, anything that can tell me exactly, what the cause of someone's pain is or where it is or what the quality is. And so it can be very difficult to kind of know exactly what's going on. But I think that we know that there can be a muscular pain that is kind of neuropathic in general, but then there can also be pain from different complications of myotonic dystrophy. So if you have scoliosis or curvature of the back, that can cause pain. If you have a joint issue like a joint contracture, similarly, that can cause pain. So there's so many different reasons. But I think one of the kind of uniform ways that we can manage this is by making sure that we are exercising, getting physical activity, drinking enough water is so, so important. That's why I got my jug here, so I can practice what I preach. And really listening to our bodies. There will be times when you need to rest. And so of course, not every day is going to be a day where you're, getting in your full activity, but to do as much as you can to keep moving, and then working with your doctor to find out, is there maybe a secondary cause? Is there other testing that needs to be done? Or is this a time where we try, a medication in addition to everything else? So I think it's it can be a very individualized kind of workup and management.
True. Good point. That actually segues into a question that I saw in the chat. Can myotonic dystrophy 1 cause sciatica and arthritis on both sides of the lower back? I know a couple people had questions about sciatica.
Mm-hmm. That's a good question. I think the kind of sciatica symptoms are more likely to be kind of a consequence of the myotonic dystrophy, and whether that is a muscle strain or tightness of different muscle groups that's occurring in that area, as opposed to a true nerve problem. It's kind of hard to say, but that is a very common reported issue, that there is that kind of lower extremity pain. And so stretching again can be super helpful for that, as well as massage, and doing different kinds of physical therapy activities too.
Great. Thank you for the resources. Somebody asked, my hands keep cramping. Is this from myotonic dystrophy?
Yes. And so most likely what that person is referring to is that hand grip myotonia. So when you perform a maneuver, the muscles are activated, and then the body has a hard time relaxing the active muscles. And so that is what we call myotonia, but it can look, like a cramp. And so, so that is a feature of myotonic dystrophy. And that is one of the things that can be treated with the medications like mexiletine or lamotrigine.
Great, thank you. Another question that was submitted upon registration, and I hope I pronounced these right. Are there any new medicines to address fatigue? My son was allergic to Nuvigil and Provigil.
Mm-hmm. And so, yes, those are names for the modafinil that I discussed. And that is just one of the medicines for that daytime fatigue. There are other medications that are commonly used also for things like ADHD, which can be your other stimulant medications like Ritalin or methylphenidate. And so there's a very long list of them. And so usually we try to kind of start with one, thinking, oh, looking at the mechanism of action and my patients, whether it comes in liquid and all of the different kind of features of each one, and we pick which one we think might be best. Sometimes we strike it, head on and it's the perfect match, but sometimes it's not. And then we have to move on and, pick a different one and try something else. So unfortunately, it can be a little bit of trial and error. And so it can be difficult to know which one will work best. But I encourage you to just, go back and talk with the doctor and see if there's a different one that can be tried, because there's a lot of options.
Great. It's nice to know that there's options out there. Is there any correlation between the length of the repeat region and the severity of symptoms?
Yes, typically we do see that with increased repeats, we do have more severe symptoms. The tricky thing, and why a lot of labs don't even report the exact number of repeats nowadays, is that the number of repeats can be different in different organs of the body. So the number of repeats in the blood might be different than the number of repeats in the muscle, and so on. And so it's not an exact science, but we do typically see those with more repeats have earlier onset of disease, and then more severe symptoms. That's correct.
Thank you. Do you know why fibromyalgia tags along with these diseases?
Mm-hmm. And so fibromyalgia is a chronic pain syndrome, and the chronic pain that can be seen in myotonic dystrophy can have a lot of similarities. And so I think it's kind of, I think of fibromyalgia being as more of an idiopathic, like we don't really understand why it happens. Whereas the chronic pain in people with myotonic dystrophy, I feel like it's because of myotonic dystrophy. And so, but I think it's kind of splitting words a little bit. They're both kind of trying to describe this chronic pain that it doesn't have a cause that can be pinpointed so easily as like, oh, I broke a bone, I have pain from that. It's a little bit more abstract than that and harder to describe and multifactorial. And so I think that's why fibromyalgia is kind of commonly kind of used, I think, as a term, because that's also something that people know and understand.
That makes sense. Thank you for explaining that. This next one, I think you touched on taking two medications, and this says, in what ways are the two medications helpful? What benefits have been seen by people taking these medications?
I don't know if someone wants to pop in the chat of which medications, if that was your question.
If you wanted to, let's see. We can always go on to the next one and see if that person wants to chat in those medications, and we can go back to that. So for the next question, is it common for juvenile onset to have atrial septal defect?
Mm-hmm. So structural changes of the heart are not as common, but can be seen. I would say atrial septal defects are just in general some of the most common cardiac congenital defects in general. And so I think it also makes sense that in a condition that is fairly common that you could see kind of overlap as well. And so I think that's most likely kind of the reason there is just that even though they're both kind of rare, they're the more common of the rare, and so they can be seen together.
Perfect, thank you. And it looks like Kathy did pop into the chat. I don't know if you're able to see that, regarding the two medications that were helpful. What benefits have been seen by people taking these medications?
Yes, and so mexiletine and lamotrigine are two different options for treating the myotonia, or the delayed relaxation of the muscles. And so what people typically see is that they have less of that. And so they can use their hands more freely. They can, open a jar without their hand getting stuck, or, shake a hand without their hand grip, getting stuck there. So that's what those medications are targeted towards, is strictly decreasing the myotonia. And so I wouldn't use those medications together. It's usually, if your doctor decides that you're a candidate, for mexiletine, I think that's most commonly the one that's started with, just because we've been using it the longest and have a lot of data behind it. But if maybe you have a rhythm change to the heart, you might start with lamotrigine. There's a long list, again, just like the other stimulant medications, of different things that can be tried.
Great, thank you. And we are going to take just a couple more questions because I want to be respectful of everyone's time and make sure we get to Dr. Evans' presentation. So this next question is related to sleep. Are very vivid dreams related to myotonic, and does this affect the quality of sleep?
That's a good question. I don't know if I know the right answer for that. It's not something that I've heard reported from my patients or seen much about in the literature, but it's definitely possible. So that's an excellent question. You stumped me.
What kind of magnesium do you suggest?
Really, whatever is easily available. Usually, a lot of my patients will do like a magnesium gummy that you can just buy easily at, CVS or Walmart or wherever is accessible.
Perfect. Can someone with myotonic use medications like Wegovy and Ozempic?
That is a very good question. Being a pediatric neurologist, I don't have as much experience with those medications. But I do think that maybe in certain situations it would be considered. It would have to be with kind of extreme caution because anything that could cause significant weight loss could, affect the muscles as well. And so we would want to make sure that we weren't seeing muscle breakdown with weight loss and that it's done in a very safe manner. And so I think that would be a very individualized discussion, with your team of doctors to see whether that could be a good candidate for you.
Great. And then I have two questions that seem pretty related, and these will be our last ones. So someone said, I know you mentioned apathy as something seen in myotonic 1. My daughter and I see it a lot in my wife. Could cognitive behavioral therapy potentially be helpful for this? Or is this just something we will have to deal with?
No, I do think that cognitive behavioral therapy can be very helpful for that. There were actually some studies that looked directly at that and found that CBT, was beneficial, improving social interactions and some of those apathy symptoms. But with the apathy, the desire to participate in something like that might be a little bit lower, and so it could be kind of a difficult kind of coordination to get someone to want to participate. But I think if you do get the buy-in from a loved one, that it could be very beneficial. So I think it's definitely something worth looking into.
Yeah, it looks like somebody else just on that same topic said that they wanted tips for getting their daughter moving because they're not sure if she doesn't want to do something or can't do something. So it sounds like that's very similar in that aspect.
And that can be really hard, with children, especially, and I'm not sure if the daughter is an adult child or a pediatric child, but just from my experience in pediatrics, knowing how much to push and when is the right time to say, okay, you can do it, and give them some encouragement versus allowing them to rest. And I think it can be a really fine line and a difficult balance as a parent to know exactly when to do which thing. And so I think it can take some kind of strategizing and trying to figure out what works individually for your child to keep them motivated. And so sometimes working with people like a play therapist to help kind of sort out some of those things can be really helpful. So that's kind of the little kids version of being able to do therapy and CBT. So I think that could be a really helpful thing to look into.
Yeah, that's a great idea. Well, again, to just be respectful of everyone's time, I'm going to go ahead and close out this Q&A session. But Dr. Batley, thank you so much for your time, expertise, and everything you do for the community.